If you enjoyed podcasts like this, you should check out our other shows on Health Podcast Network. For example, Highway to Health podcast, hosted by Jeremy Quinby, provides guidance, quality resources, and inspiration for anyone seeking wellness in mind, body, and spirit. There's an episode that you should check out called The Value of Our Emotions, where Jeremy helps listeners understand the role emotions serve and what we can learn about our present state by staying attuned to them. Check out Highway to Health podcast on your favorite podcast platform or visit healthpodcastnetwork.com.
Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. Welcome back to Healthcare for Humans, a podcast dedicated to helping healthcare professionals like you provide the best care possible to diverse communities. I'm so excited to have you back to join me for part 2 of our series on reflective, equitable communication with Dr. Marie Liebel, founder of Health Communication Partners. So in the last episode, we explored a few things: Dr. Liebel's journey from education to healthcare, the power of language in shaping patient-provider relationships, and of course, the importance of reflective practice, which is a core component of what Dr. Liebel teaches in improving communication. If you haven't listened to part 1 yet, I highly recommend going back and starting there to get the full context of our discussion as we continue to part 2 today. So for part 2, I want to share a personal reflection that has shaped my own approach to patient care. In my years as a family physician, I've learned that the best care isn't always about following one-size-fits-all algorithms or guidelines that is so pervasive in medicine. Instead, it's often about asking myself, what is the right thing for this unique patient in this specific context right now? This question is deeply contextual and requires me to truly listen, understand, and adapt to the individual needs of each person I serve. It's really a lesson that has transformed the way I communicate with and care for my patients. I suspect many of you have had similar realizations in your own practice if you're currently practicing medicine. In this episode today, Dr. Liebel helps me grow in this belief by focusing on 3 key points: the importance of reflective practice, which we've talked about, but we're going to double down on it, on how studying your own patient interactions and generating context-specific knowledge is going to help you become a better clinician. 2, challenging traditional communication models and embracing a collaborative, constructive approach to building understanding with patients. The language that we're using here is very intentional. We're talking about building something together, which is different from shared decision-making, eliciting, other words we use in medicine. You'll understand it a little bit more in this episode. 3rd, crafting effective language and questions that align with patients' worldviews, which is such a key part of communication. These are all important concepts that I know is making me a better clinician for the diverse communities that I serve. I'll also add that Dr. Liebel is a fellow podcaster. I haven't shared this yet, so she's not only doing work through Health Communication Partners, but also through her own podcast, 10 Minutes to Better Patient Communication. It's always so fun to connect with fellow podcasters. Our formats and focus differ a bit. Hers is a lot shorter, less than 10 minutes often, but we're on a shared journey to create more equitable health. So I so appreciate connecting with Dr. Liebel through this medium and building a relationship with her. I hope this conversation will inspire you to reflect on your own experiences, challenges, and opportunities for growth to provide more equitable, patient-centered care. If you want to learn more after listening to this episode, I encourage you to explore the wealth of resources available through Health Communication Partners. Let's dive into part 2 of our conversation with Dr. Marie Liebel. Yeah, a few things I want to reflect on here. One is how I'm a fish in water, like we all are. And that metaphor of there's a fish swimming in water. Somebody else asks, how's the water? And the fish says, what water? Because you're in it, you don't see the assumptions that we hold. And this assumption of there being only one right answer of one way it should be is deeply baked in. And that informs the idea of whatever intervention we do in medicine is universally true. If we know it's right, then it's right for everybody. Because we like to take things out of context, study it, and then say in any context it should work, which sometimes is not true for certain things with caring for people. People know that intuitively, but naming this feeling that we have of what is missing around here. And then going back to that interaction that I had, I've played this out multiple times. Sometimes I am a consultant. I say, hey, this is what I think is going on. These are the potential options. We could start this medication right away. We could start this medication together. What would you like to do? And the patient goes, you're the doctor. Why are you asking me? This goes back to the context of what are the expectations of the patient's coming in, and have I listened enough to understand what they're requiring? They want more confidence in me because they're doubting my expertise when I sometimes phrase it so openly. Other times, if I act as the expert, I say, for this condition, you don't need any medications. You have a cold, just go home and drink tea. And the patient's actually quite disappointed. They're like, I waited 4 weeks to come see you for 15 minutes. I rearranged my whole schedule today. And you're telling me just to go home and drink tea and buy this medication over the counter. So as I learned from that is there's a difference between over-the-counter medicine and me prescribing a medicine, because there's some increased power in that. We don't need to go through all the scenarios, but what I am reflecting on and pointing to is your question of, am I reflecting on my own practice? And do I understand this patient in front of me, this community in front of me, what their expectations are? And how do I meet them where they're at with my language use, with how much option, choice, and confidence that I want to convey? And it gets quickly complicated because I'm like, hey, I got 15 minutes. I'm just trying to give you this medication,
Right.
go in. And you're like, what are you talking about, Raj? Like, you're doing all this?
The questions that I get from people are often, just tell me the thing. I need to do it. Please just tell me and I'll say it. And I hear that frustration. And I also hear the deep desire to help. It's like, I want to help. You're an expert. Tell me what I need to do and I will do it. And that I take very seriously. And I also take very seriously the commitment there to help. And sometimes when you've got to tell people, we need to step back a little. I get the frustration because people can start to be afraid that, oh my gosh, do I have to throw out everything I knew about communication? Do I have to throw out all the cultural competency stuff? Does none of that stuff help? No, of course it helps. Of course you're going to need that. And the empowering part is we are all creating language on the spot. We're all recruiting words on the spot every moment, all the time. No one, including me, as fabulous as I think I am, no one, including me, can prepare you to speak with everyone you're going to speak with across your career, because those patients are going to change as you know them as well. So it's abusing people of this kind of pressure that you're supposed to know the right thing to say at all times. And if you didn't, it didn't mean you didn't study enough, you didn't memorize enough. No, you're recruiting language on the spot with all of the things you are noticing about this patient, with all of the things running through your mind about clinical decision making. You are recruiting language on the spot. Let's study that, because that is where you're going to learn about what you do, what is working for you in your context with your patients. And that's immensely empowering, because you don't have to go out and memorize something and worry that you've forgotten the one right answer.
Exactly. The best clinicians that I talk to ask themselves, for this patient at this time in this room, what should I do?
Mm.
There's a deeply contextual question they're asking themselves, rather than, for this disease, what do we know about it? And what am I supposed to do? I feel like so much of language is context. And that's one of the things that I learned from your work and from talking to you.
Oh, well, thanks for that. I think there's been a lot of pressure on clinicians to be perfect. There's been a lot of pressure to come to a quick solution as well. And that is working against all of our interests right now. I think when you're doing this kind of interdisciplinary work, you really do need to be careful and slow down a little bit, slow the train down and take a look at what you're doing and give yourself a lot of grace because this is hard work. And I think paternalistic medicine had it easy because I had a clinician who explained it to me this way. He said, the cultural legacy of patient education used to be tell them what they need to know and hope they heard. What do you think about that, Raj?
Yeah, I think it goes back to what I was saying. We told them what to do. They didn't follow it. They're non-adherent. They're frequent flyers. They're ruining our healthcare. They need to be better. And we've come a long way, but they're expensive. Why can't they figure it out? We've told them multiple times to take the medication. And if they did, it would be better.
Again, assuming that's the deficit perspective, assuming this person is less than me, the way they think is less than the way I think. Their way in the world is less than my way in the world. And it's insidious, and I don't think anybody sets out to be this way. And it's a lot of what we've inherited. So when I tell people, like the paternalisms and the language, the paternalisms and the communication, it can be in assumptions about how we're going to study people. There's lots of assumptions there that are kind of deficit in nature, and nobody means for them to be there anymore. So there's a lot of opportunity here to find when you put on equity lenses, things that you didn't see before, including things that you're talking about, the ways that we are conceptualizing patients, the assumptions that we have about what they know and do in the world, assumptions that we have about our positionality in reference to making decisions for them. So the fact that health literacy is a field, the fact that people like you are asking questions like the ones that you're asking, that you're having me on a show like this is only good. It's only hopeful because there is no lack of scholarship out there on the things we are talking about. I've got that backpack of the best studies in the world from the University of Pennsylvania. I'm just sharing them out with anybody who's willing to listen. That's why I started the show, man. I had to be able to tell people about this stuff in tiny little bits.
Yeah, I want to bring in another concept that's linked to this conceptualizing of the patient. We talked about health literacy, and one thread of that conversation was about how we label people illiterate during health. There's the idea of othering that I talk about a lot, and the process of constructing otherness. We do that in medicine a lot. I am a clinician. I'm also a leader. I do some health equity work. So in all those realms, there's a way of othering people. Well-intentioned or not, it happens. As a clinician, I think of non-English speaking patients. Somebody labels them that, and then now I know I need to do something differently. Warranted or not, we're already starting to say these people are different, so we need to treat them differently. And sometimes that can end up placing expectations on this group. So as a health equity leader, one thing that happens is we form labels to then groups, vulnerable, marginalized. And this powerlessness can also link to this idea of saviorism, right? There's this cycle that starts and people don't know they're in it. For example, I was talking to a clinician who was in a community health center who says, oh, I could never work where you're working. My patients, they don't use a lot of secure messaging and they're really grateful for the care that I give. Well, pause there. This idea of people that I take care of are suffering and they're really grateful for me. What's unsaid is they don't challenge me. They don't bother me in a way that makes me uncomfortable. They listen to me. There's all these unsaid things in there. But then we say that's what makes a good patient and this community great is they are so disempowered. They're not challenging with authority, right? So you have to think really deeply on these statements because you go in with that sensation to make decisions for people. What do you think of my reflection in this?
Yeah, absolutely. I think what you're getting at, and this is something where I'm so eager to be in conversation with people about issues of power as they relate to communication. What you were talking about is the power in the patient-physician relationship, that the way that this physician was experiencing it and revealing that their attitude toward it in their conversation with you. So anytime someone is willing to talk about power, I'm down. Let's go. Let's talk about this. The way that the research traditions in communication that I come from in language and literacy, it centers power. It centers culture. It centers context. So I will talk about power and language with you all day long. There's a few things I can tell you, and one of them is that your language is always already connected to power in one way or another. You don't get to neutral out of this. You don't get to nope out and say, oh, I'm just talking. You are always talking in a way that has to do with power in one way or another. And this conversation is one that many people are having, and I'm very excited about, because people want to do the right thing. People want to be better at their jobs. People want to help patients have better outcomes. People want to support their colleagues. People want to support the missions of their organizations. So people are willing to go, whoa, how am I making a power play here in my words and I don't even know it? So the fact that you are looking at your patient interactions, thinking about power, how am I empowering, how am I disempowering, is a massive step toward that kind of awareness of the shared decision-making that you're aiming for. There's a lot of power issues there in shared decision-making as well. There's a lot of conversations we can have about power and its relationship to communication that don't have to do with calling people names. And that happens too. That's bad. Don't do that. But it have a lot to do with our positionality and what we think is normal and the culture of medicine, air quotes. So that is also why people who study language like I do will want to know what's the actual interaction that you had. What did happen there? What was said, and as close to the language that you actually used as possible? Because we want to help you get into what were the power issues here. And we can only do that if we know a little bit more about the context in which these words were said.
Exactly. And I do think there's power in also who defines and names the language. So going back to that, like vulnerable, marginalized, and there's a shift to some people saying historically exploited. Let that land for folks, because if you say vulnerable, you're stating an identity for folks, then they're not always vulnerable. Or marginalized,
right,
saying, hey, you are in the margins, meaning,
right,
hey, I'm part of this community, right? And this
absolutely,
historically exploited shifts it away from naming the individual to, hey, what we've done to you, and lets them define themselves. But as people hear these different terminology, it's important to call it out. And there's definitely going to be some listeners who are so over language as
right,
because it can become polarized, and somehow people are worried about saying the wrong things too. And I want to bring back people who are there to say language is important in this conversation for me, and why we talk about it a lot, because it's leading to thoughts and actions and behaviors in you that you may not realize, but it's happening because language leads to other thoughts and other words. And that's just how our brain works.
You're so thoughtful about this, Raj. And I love that the point that you're bringing up right now, there's so much that we do with it that we are not conscious of, because that is how language works. So actually taking notice of your language takes a lot of effort, because so much of it just slips right past us because it needs to. Like, we don't have to spend a lot of thought on our language, because if we did, we couldn't drive a car and talk. We couldn't have a conversation. Like we would have to stop everything else just to speak. Very hard to think of a human activity that doesn't also get accompanied by language. Language does have a way of slipping by on us. So even just the effort that it takes to slow down and notice it is something to celebrate, something to say, hey, you are taking a moment to pause the train and take a look at your language. And that's hard. The other language that you made me think about is the ways that patients can get framed as language being a barrier or culture being a barrier. And that is, again, an inherited way of looking at it, but you realize that it's only a barrier for you. It's a barrier in the health system. But to say patients have this barrier only because of the way that the health system works, that language is not a barrier for them in the world. Their culture is not a barrier for them in the world. Because of the culture of the health system, because of the language of a health system, their language and your language are not matching with each other. So to say that their language is a barrier starts getting a little close to a deficit, like this is the patient's fault, when really it's only a barrier because of the rules that you guys have in your system. And helping people be aware, as you are, of just how many home field advantages you have as the physician in the system that is geared to work better for some than for others is a lot of the conversations that I'm in with people.
Exactly. Let's shift to shared decision-making to hopefully find more concrete moments for our listeners here. I'll talk about some scenarios I'm told to have shared decision-making for. I want to talk about it from this framing of what we've been talking about, language, and what does this look like? For shared decision-making, there is an excellent article that you had shared with me from your backpack that I'll put a link in our episode of this article that reviewed all the different definitions of shared decision-making. And some of the key takeaways from it was how clinicians are often the communicators. I tell people about certain topics. Shared decision-making that I'm sometimes doing. Prostate cancer screening. Should you get antibiotics for your ear infection for your kid now or wait a little later? Which medicines for diabetes should you start? Those are only a few things. There's a whole list of them. But in the definitions for shared decision-making, I'm the communicator. The patient is a cognitive participant. What that means is they're not communicating anything with me. They're feeling, they're thinking, they have some values that's supposed to happen in part of the process. And then there's also the power dynamic, because some of the definition is that I elicit patient perspectives. Like somehow I'm pulling it out of them forcibly. Tell me what you really believe in value, because then is how we can do shared decision making. And that really stuck with me. I was like, yeah, like that language elicit, now I use all the time. I'm eliciting things from my patient, which is not a common word that we use in other contexts. So even the definition, it encompasses it well, that shared decision-making is a gift that the clinician has the power to offer. And the relationship is often asymmetric and only one party speaks. Going back to some of the examples that I give, antibiotics for ear infection, a kid's old enough that we can wait to see if it gets better, or prostate cancer screening. I give them all the information data, tell them everything we know, why, the pros and cons. Then I bring out what is truly patients' values, because maybe they don't know, but I got to bring it out. When you came onto the field and saw how shared decision-making was implemented, what did you see was incorrectly implemented from the intention of it? And how can we do it differently?
I love that, because it gets to some bigger issues that I think people are right up against as well. And I'm going to take it back to systems that the medical community and to an extent the public health community has also inherited about communication and about patient education. It still has a feeling in all the conversations I'm in that are about patient education, about patient communication. It still has the feeling of an afterthought. It still has a feeling of, we'll have a conversation about that if we have time. So it's still trying to fight for legitimacy. Coming as someone where this is all we talk about, it was obvious that one of the biggest impediments is just the inherited systems, the inherited ways of thinking about communication, which in of themselves aren't bad, but it can make other conversations very hard to have. It can lead us down all of our disciplinary histories, lead us down certain paths and not others, make some questions askable and not others. So the fact that there has been the communication research that I've seen in the health sector has been highly influenced by like the individual biomedical model, by the need to isolate variables like you and I have talked about before. And when you take that kind of an approach to communication, you're going to be able to ask certain questions and not others. So now that people have gotten, okay, this one-size-fits-all approach to communication was doing really great for some people, but we've lost everyone on the margins. So now we need different tools. We need different approaches. What else can we do? Sometimes we got to go way back to, what do you think communication really is? What do you think you're doing here? What kind of assumptions are you making about the patient and their thinking, their words, their world? And what do you think the communication is going to do in that space? So when you're asking about shared decision-making, it is also very much a teaching and learning scenario. And the pieces of the history of communication research that has struck me is, as I said before, it centered the clinician, which is fine. Now, people are aware that in a conversation, there isn't just talking, there is also listening. And there isn't just the provider, there is also the patient. We've got two people talking and listening. Oh, and we also have a physical context, and we also have an emotional context, and we also have a psychological and cultural context. And all of those are part of what goes into how we make meaning when we communicate. So, are you willing to take a look at them? Are you willing to take a look at how one size fits all doesn't work? Because there are the tools to do that. We've got gobs of research. When you're looking at shared decision making, I want to invite people to talk to your colleagues across campus about what theories of language do they have? How can they help you expand your repertoire in terms of how you are researching language? I would also encourage you to talk to your colleagues across campus about learning, because there is, again, an enormous amount of knowledge here that could be helpful for ways of conceptualizing the teaching and learning process that is not delivery. Amazon delivers. They're not delivering education. I've used this story before, but how do people say like knowledge transfer? And I'm like, it's not like it's a pocket snack. Like I have it and now I'm giving it to you and you have it. Understanding doesn't work that way. But I think people know that. People get that. You have to build an understanding over time. But when you're wanting to research that, when you're wanting to understand more about shared decision making, there's an awful lot of resources that are available to folks. So I want to encourage you to reach out to your colleagues in other disciplines.
Thank you so much. I can imagine listeners, some feeling like, oh, I finally feel maybe not alone. That thinking of, hey, I thought something was wrong with this field, but everybody around me is trained in the same field and we all can't name it. So maybe some people have a sense of relief knowing that, yes, there is something within the field itself that needs to change. I can also imagine some people feeling overwhelmed at this point. We've talked about a lot of concepts and challenged their fundamental beliefs on communication. For people who are listening, what can I do now? And what should I do in the future?
So I started a podcast series because people are asking me this question. And when I wasn't even going to start it. I was like, I'm not sure I'm going to have enough topics to talk about. It's been going for 6 years this month. Every 2 weeks without fail for 6 years, because there's so many different questions and each one deserves some thought. So the thing I am going to tell people is that I'm going to encourage you to be a student of your own practice. That is, you are allowed to study what you do and you are allowed to generate knowledge about what you do, because no one knows your context and your patients and your job better than you do. And that alone can open us up to seeing better ways of doing the thing that we do that are only locally relevant. That you're not trying to solve this problem for everybody. You're trying to solve it for you and your patient right now. And there are ways of doing this. As a research tradition, I also come from the University of Pennsylvania. I'm inviting you to something that has a long life and a lot of a robust research base underneath it. It's not just a feel-good measure. The other thing I would say is, again, my single best piece of advice is imagine people are already doing the thing that you're asking them to do, or they're on that path. And if they want to make a switch in the way they're thinking about language from something that's like delivery, if you're delivering patient education and you're feeling that, I'm going to offer a different metaphor, and that's a construction metaphor, like building a house, building a park, building a relationship. If you want to think about constructing, and it is a construction process on both of your part, because you're bringing resources, you're bringing assets, you're bringing cultures, and you're bringing them to this specific point in time and place where you are together with your patient. You are building something together with your language. So thinking about the thing you want to build and how is your language contributing to that thing, even just that metaphor can help you make some decisions in the moment.
Again, I love metaphors. Thank you so much for ending with that, Anne-Marie. It was a pleasure having you on our podcast.
Raj, thanks. And thank you for all of the questions that you're doing. You're doing a lot of work in reaching across fields. And it was a delight thinking about what could we talk about and what papers could I possibly give you to talk about this space that I think is shared between us, because it's hard for me to stand back from what I know and imagine how is somebody else seeing this. And I don't get it right all the time either about how do I step outside this and explain it to somebody who doesn't do this all the time. So in that way, we have a little bit of parallel there, and you're teaching your patients and I'm trying to teach other clinicians.
Yeah, we're in this together. That's what I like to see.
We sure are. We sure are. And I have courses if anybody wants. That's during COVID, I switched to online courses. So I do consulting and courses. And that was wild too. How do you do this work online? Oof. But I think the answer is you meet with people live. You still meet with people live because you have to.
Yep.
Thanks again, everyone, for joining me on another episode of Healthcare for Humans. If you liked this episode, as always, my ask to you is please share it with one other person and go to healthcareforhumans.org to sign up to be part of the community. I'll see you next time.
If you enjoyed podcasts like this, you should check out our other shows on Health Podcast Network. For example, Highway to Health podcast, hosted by Jeremy Quinby, provides guidance, quality resources, and inspiration for anyone seeking wellness in mind, body, and spirit. There's an episode that you should check out called The Value of Our Emotions, where Jeremy helps listeners understand the role emotions serve and what we can learn about our present state by staying attuned to them. Check out Highway to Health podcast on your favorite podcast platform or visit healthpodcastnetwork.com.